Hello, welcome everybody to the SusQI or Sustainability and Quality Improvement Showcase. My name is Frances Mortimer. I'm the Medical Director at the Centre for Sustainable Healthcare, and really warm welcome from all of us to this event. CSH's mission is to integrate sustainability into clinical culture and clinical leadership and management and decision making. And just a few years ago, I and others began to feel really strongly that sustainability should be part of quality improvement, because quality improvement time when you're spent when you're working on QI is often the part of people's role or their working lives where we're encouraged to think about the system and about resource use. And also just because we need to harness all the QI work that's going on to help us to build a sustainable system that delivers excellent health outcomes within the limits of environmental, social and financial resources. So since then, we've worked with others on the nuts and bolts of how to do sustainability, how to put sustainability into quality improvement. And we've developed the SusQI framework to help us with doing that. We're not going to be going through the SusQI approach or the tools in this workshop. We're going to be focusing on showcasing how organisations are successfully integrating sustainability into QI education and into QI practice. So do look up the website for all the resources, and we'll tell you more about that later on. So this is the programme. It's in 2 sessions. The first is going to be focusing on from sort of like the educators' perspective and the organisational leads, QI leads, how they've been working to integrate sustainability into QI in their organisation. And then we'll have a brief Q&A. And then the second session is going to be some examples of particular projects that have used SusQI. So without more ado, I'm going to hand over to my colleague Kath Richards, who is our programme lead for the SusQI programme at CSH, to introduce our speakers.
Thank you, Frances. It's an absolute pleasure to be here today and to have everyone on the call with us, and to be introducing our fantastic speakers as well. So our first speaker, I'm going to introduce Iain Bestford, who is Project Director for Newcastle Improvement. Iain is a qualified management accountant with over 20 years of experience in the NHS, has been leading the continuous quality improvement programme within the Newcastle upon Tyne Hospital's Foundation Trust for the last 3 years. So thank you very much, Iain, for joining us.
Yeah, thank you, everybody. My name's Iain Bestford. I'm Project Director with Newcastle Improvement. As Kath said, I've been working on continuous quality improvement at Newcastle Hospitals for the last 3 years. I thought it would be really helpful just to start with a little bit about the organisation. Newcastle Hospital has been one of the busiest, largest and most successful teaching foundation trusts in the country. We've got about 16,000 staff, annual income of about 1 billion. And we're predominantly located across 2 main hospital sites in the city, Newcastle upon Tyne, the Royal Victoria Infirmary, which has our major trauma centre, ED department, and our Great North Children's Hospital linked to that site. And then our Freeman Hospital, which hosts our Northern Centre for Cancer Care, our Institute for Transplantation, and our recently opened Day Treatment Centre. We've been rated outstanding by the Care Quality Commission for the 2nd consecutive time in 2019, and we continue to provide high quality care, clinical excellence and innovation in medical research regionally, nationally and internationally. We continue to provide specialist services across the country as well, the range of rare and complex medical, surgical, neurological conditions, cancers, genetic disorders. And so probably fair to say that QI and sustainability have been natural bedfellows in Newcastle hospitals under the banner of Flourish, which is, I guess, our organisational development programme within Newcastle hospitals. The 2 key strands, alongside learning, celebrating diversity, staying well, and being valued and heard. And I guess importantly, in June 2019, we were the first healthcare organisation in the world to declare a climate change emergency, and we subsequently, in October 2020, published our climate emergency strategy. So I guess really, what was our problem? Because we felt as though we were in a decent spot as an organisation. We were committed to delivering on the climate change plan. So why do we need to do anything else? Well, the problem for us was that there was a lack of evidence that our quality improvement projects were having a material impact on the Trust's ambition to deliver zero carbon care. And I guess using the kind of model for improvement, we then thought, well, what would our aim be around that? What would we want to do about it? So we've set ourselves an aim to increase the proportion of QI projects that have sustainability metrics reported to 20% by March 2024, essentially from a baseline of zero. We can have a debate as to whether that's ambitious enough or not, but it's where we've landed. And I guess we thought about some of the key drivers that sit behind that. So an awareness and desire, and I think it's fair to say that our Sustainable Healthcare in Newcastle team, our SHINE team, have already, I guess, identified green champions across the organisation. So the desire to deliver on this agenda is there. Awareness with regard to it within, I guess, the realms of QI, maybe less so, and I guess importantly that capability and confidence, and I'll come on to that. Capacity continues to be a challenge in delivery of improvement initiatives in general, not just those linked with sustainability. So what did we do? Well, I guess we've decided to focus on the capability and confidence piece. We wanted to show fidelity to the model for improvement. We've been working with the Institute for Healthcare Improvement for about 2 years now, and we recognised that fidelity to a model was really important. It didn't really matter which, but we decided in Newcastle hospitals to adopt the model for improvement. So we wanted to retain that at the core of what we did. We didn't want SusQI to be seen as something particularly different. We wanted it to be part of everything that we do in Newcastle. We wanted it to be mainstream. We didn't want to be a niche. We didn't want people going up and saying, well, we're SusQI and everybody else is QI. And we recognised the talents that existed within the existing teams of Newcastle Improvement and Sustainable Healthcare in Newcastle. And we wanted to maximise the resources that we had. So what did we do about it? Well, we've brought our QI training in-house. We had been relying heavily on IHI to do some of that delivery for us. We've now brought that in-house, and we're delivering that through Newcastle Improvement faculty. And that provided us an opportunity to review the materials with Centre for Sustainable Healthcare. And I guess what we've undertaken is a series of incremental and rapid adoption. We only really engaged formally with CSH in around December, so it's been quite a rapid turnaround in order to get materials prepared. And we've had a number of our coaches attend the CSH workshops. So what have we done differently? I guess there should have been some animations on this, but it won't show in this, I guess, in the way that this is shown. But we originally in our materials had the Institute of Medicine definition of quality improvement, so they've been safe, effective, patient-centered, timely, efficient, and equitable. And following kind of the review of the materials, we've changed to embed sustainability as part of what we've done. So we're moving towards that Royal College of Physicians definition with sustainability as a cross-cutting quality domain. The other things that we've done with regards to the content that we are delivering is we've really looked at how we discuss and bring into focus measurement. So we have traditionally focused on quality, patient safety and experience, staff experience, performance, productivity, efficiency, and financial stability. So 4 key elements. But more recently, and in our latest training program, we've further adapted that and broadened the scope of measurement to specifically, explicitly discuss environmental sustainability as a key domain. And some of the examples that we've given in there, it's a number of miles travelled by community team visits, or reduction in carbon footprint as a result of reduced length of stay and being able to reduce overall bed capacity. We further added in health inequalities, recognising that as a key component of delivering on QI as well. So we've taken the opportunity not just to build in sustainability and then to work through SusQI and CSH, but also to look at those other factors that are really important to us as an organisation. And with support of CSH, we've also looked at embedding other aspects of and improving on other aspects of our training by including things such as the social determinants of health. I guess there might not immediately be apparent that it's sustainability, but they're important considerations nonetheless. And I guess just to finish with a couple of comments that I've received from some of our faculty. So a couple of the guys who work in our team in Newcastle Improvement. So Chris Ellis, who's one of our quality improvement program managers. Chris said that when we were given an example of a project, we're bringing in the sustainability of domain of measurement, even if that wasn't the primary focus of the project. For example, the project focusing on reducing length of stay is now also linked to a potential reduction in our carbon footprint. And Sarah Watts, one of our improvement facilitators who attended one of the SusQI workshops, has really grabbed this and then running with it. You know, she says, when I'm coaching the team, feel able to highlight potential sustainability metrics. And I think the confidence that the faculty have gained through the engagement with the Centre for Sustainable Healthcare, being able to introduce some of these concepts and share with the teams with which we're working has been really important. So that's the end of my presentation. I'll stop sharing and I'll be happy to take any questions as part of the panel session at the end.
Thank you so much, Iain, for that. And we have got a couple of questions, so we'll hopefully be able to get to those in the Q&A. Brilliant presentation, thank you. So our next speaker is Dr. Jocelyne Cornish, who is the Senior Lecturer in Nursing Education at the Faculty of Nursing, Midwifery and Palliative Care at King's College London. And has an education portfolio covering the principles of research methods, quality improvement and sustainability. Jocelyne is a registered nurse with both the Nursing and Midwifery Council and the Singapore Nursing Board, and also has extensive research experience in covering a range broad of topics with a central focus on organisational provision of services. Jocelyne, in her current work, evaluates educational interventions to support students in the transition to university. So welcome, Jocelyne, and thank you so much for being here.
Thank you for the invitation to present at the SusQI Showcase today. You've asked me to present on how we embedded sustainable quality improvement into the curricula in the Faculty of Nursing, Midwifery and Palliative Care at King's College London. So I'm going to start with a timeline. The flowchart on the left shows how we embedded the Centre for Sustainable Healthcare Materials into the faculty curricula between 2021, and this was when we joined the pilot project, to the current day when we have a further 5 SusQI leads being trained through our academy membership with the centre. In the pilot project, 10 members of staff undertook the Teaching Sustainable Quality Improvement course and co-delivered the 3-hour workshop using the centre's educator pack as a base for the content, alongside, in the first instance, with our CSH mentor. We've continued those workshops in the programmes following the next academic year. In January 2023, in addition, principles of sustainable healthcare and QI methods without the full workshop were delivered in other parts of the programme, so via individual modules, for example, in midwifery and mental health care. With a view to incorporating those into existing timetables within this academic year. In January 2023, we were accredited with established beacon status with the centre, and the acknowledgement of that achievement led to the option for applying for faculty seed corn funding, and that has allowed us to pay for the academy membership to update the existing leads that we had with additional courses, and also then to provide training for a further 5 new leads. And those leads will be embedding the material into other programs that we have. So 2 of the leads will introduce the sustainability content to our international programs. One of these is the BSc for qualified nurses in Singapore, and the other will embed it into the MSc clinical nursing program, which is available to international students that come from all across the world. A further 2 of the new leads will introduce the content into our post-qualification modules, 1 in critical care, 1 in prescribing modules, and the last will review the material and where it's embedded within the midwifery programs. The sustainability content fits well with the modules that we run that focus on quality improvement methodology and leadership in nursing and midwifery. These are typically delivered in the final years of the programme. Reducing health inequalities and preventing ill health is just the core theme of the public health nursing programmes for our health visitors and school nurses. And so it's quite easy for them to put the SusQI principles into that particular content. So in preparing the presentation, I thought about the factors that had aided this progression. I think initially the liaison with the centre in the pilot project was obviously a key factor. And we were supported from the initial staff training to delivery of the material in classes by our centre mentors, Victoria and Siobhan. The other key factor was having module leads with an interest in sustainability, because these were able to see where the content could fit into their respective modules and programmes. Also, having the educator pack reduced a potential barrier to getting that material into the programme in lecturers trying to find the time to deliver or develop materials from scratch. And it meant that we could adapt the materials that we had from the centre to suit the necessary content and even timetabling barriers. So for example, when you only have 1 session and it's a certain length of time, you can't necessarily deliver the whole workshop, for example. As well as delivering the material to students, we also have negotiated administrative processes to update module aims, descriptors and outcomes to make sure that the sustainability focus is within the assessments. And I think we need to acknowledge our professional services staff, because in telling them what we needed to do, they managed to push us through those processes quicker than we may have done otherwise. And we also had quite supportive faculty managers. Once they were aware of the activity we've been doing, they pointed us towards opportunities for funding and also enhanced communications about this work at different fora, different levels in the university. Relatively new within the last couple of months, but now a key driver going forwards. We have a new action plan for university climate and sustainability. It's not that sustainability wasn't an interest before in the strategic objectives in the university, but that there's now an action plan that's been developed to cover kind of a wide remit of objectives. And so the key message of these university strategic objectives is to demonstrate sustainability in all we do, not just within the teaching, but the way we work as a whole, manage the buildings, estates, etc., etc. But so in order for us, the faculty, to look at the action plan and say what impact we've made, we need to gather evidence of the impact of that work. So I'm going to take the adult nursing as an example. On our undergraduate pre-registration programmes, we saw the teaching impact in the evaluation of the workshops by the students. They were surprised about the environmental impact of the health service. They noted how their eyes were open to reducing energy waste or preventing waste, and teaching others about these concepts. These students can choose to do an assessed TED talk relating to sustainability in one of the modules at level 6, but they also need to do a quality improvement proposal for their dissertation, and they can also show the application of that learning there. These are the healthcare service leaders of the future, and so their awareness has the potential to influence a change in practice going forward. And we presented these evaluations at the last SusQI showcase, so I'm not going to focus on those here. Both the workshops were well evaluated by both undergraduate and postgraduate taught students. Instead, I'm going to focus on the actual patient benefit from some of our MSc student quality improvement projects in their own clinical organisations. So this is the dissertation assessment for advanced clinical practice students. They come from a wide range of professional healthcare disciplines, and they can choose to use a SusQI framework as the design for their project, although they might not do so. However, since focus on sustainability has been included in the assessment criteria and the learning outcomes, there has been an increase in students in the latter intakes, specifically discussing environmental issues for their projects in the discussion section of their dissertations. We are currently categorising the nature of the projects in an evaluation of our teaching work, but the students have been doing things like implementing medication reviews, increasing engagement of patients with screening, introducing reminder system to reduce did not attend and re-attendance for another appointment. Some of the students have also estimated cost savings from the reduction of resource use to demonstrate the impact of their work. So the top one I've given you here has done that. Of the 3 projects where the details are given here, these students had the opportunity to attend a SusQI workshop. This was an April cohort, and the workshop at that time wasn't embedded within the timetable, but they had an opportunity to attend with the September cohort and may not have done so. The following cohort, the September cohort, around 65 students, they did have the workshop embedded in their timetable. Now, these students are not submitting their projects until September, because they get a whole year to do this project. And so it will be interesting to see whether any of them did use a SusQI design and talk in terms of the triple bottom line within their projects. I know of at least 2 that were considering that approach so far. So lastly, in making sustainability a focus of what we do, we're in the initial stages of a project to green up the waste from our clinical skills sessions, and we ran a climate cafe in collaboration with Heather Bade and Suze Thompson from University of Brighton, with our 2 student interns and our clinical teachers to look at what the nature of waste produced by clinical skills simulation teaching. The project will look at the carbon footprint of those skills teaching, and this climate cafe helped us to identify some of the interventions we can put in place to reduce the carbon footprint.
Thank you so much, Jocelyne. That was brilliant to hear about all the work you've been doing and such important work with future healthcare professionals. So thank you so much. Our next speaker is Dr. Jenny Girdler. He's a postgraduate trainee in oral and dental surgery and is currently the NHS England NetZero Sustainable Dentistry Fellow. Jenny has successfully delivered teaching and quality improvement initiatives to embed sustainability into medical and dental training programmes. And we're really lucky to have Jenny with us today because her expected due date is very soon. So we're very grateful for her to be here. So thank you, Jenny.
Brilliant. So thank you for the introduction. So I'm Jenny and I'm currently doing a leadership fellowship in NetZero Sustainable Dentistry, and I'm out of programme from oral surgery dental specialty training. And I'm presenting today on behalf of the NHS England Yorkshire SusQI team. So I want to provide an overview of a sustainable quality improvement programme that's been implemented in Yorkshire for dental core trainees. So where did it start? So for those of you who don't know, dentistry makes up 3% of the carbon footprint of the NHS in England. The programme began with Ghazala Ahmed Mir, who is our Associate Postgraduate Dental Dean and TPD for dental core training, realising that she was developing leaders in the NHS without any sustainability training. As a surgeon, she also observed the enormous waste produced in the operating theatres, and she believed that the DCT programme could produce safe patient care pathways with a reduced carbon footprint, and she pledged to plant sustainability training into their programmes. So first of all, what is dental core training? So allied health professionals are not always familiar with this quite niche group of people because comparatively our numbers are small compared to other specialties. So dental core training follows a year of dental foundation training and offers dentists the chance to enhance their clinical and professional skills in dental specialties in a setting very different from general dental practice. Most of the posts are based in hospital trusts, with a few aligned to salaried dental surgeries. There are 3 standalone years, DCT 1, 2 and 3, recruited annually. And after DCT 2, trainees are eligible to apply to enter dental specialty training. So what did we do? So the aim of the programme was to ensure that dental core trainees are able to understand the interconnectedness of climate change and health, be able to apply the principles of sustainable clinical practice to dentistry, and contribute to a net zero NHS system. And the programme's been running annually since 2017 with the help of Frances Mortimer at the Centre for Sustainable Healthcare, who set it up with Girdler. And it's now a compulsory requirement to complete the training year. And it's delivered across 3 sessions. So 1, there's an educational workshop on SusQI. 2, there's a project development workshop. And then 3 is a presentation session where these are assessed and they can get prizes, first, second and third prizes are awarded. And the outcome is to support dental core trainees to develop, implement and then present a SusQI project. They follow recognised CSH SusQI methodology, as well as the project report templates. And all trainees are provided with a list of pre-reading material and asked to prepare a short presentation on one of the principles of sustainable clinical practice to deliver during the first workshop. So it's not information overload at the first hurdle. And this is an example of the pre-reading that was that has been produced and adapted year on year from the CSH. I understand you probably can't see this in much detail, but I think this is going to be made available as a linked resource in the SusQI report, which will be available through the networks after. And similarly, this is the programme example of how the day runs. And again, this will also be made available as a resource that you can have a look at for those who want to implement similar. So these were the learning outcomes. We wanted the dental core trainees to be able to recognise carbon neutrality within the context of delivering healthcare services, demonstrate application of these principles in practice. We wanted them to have the knowledge and tools to be able to deliver a SusQI project, and then this shows evidence-based behaviour change in the workplace. And as well, we wanted to give them the opportunity to present their project at regional level with a chance to get a prize as well. So it's win-win. And what did we find? So on the left, this is an example of a presentation from the presentation day. And on the right is an anonymised example of a SusQI report using the CSH template. So each year, between 20 to 30 DCTs present extremely high quality SusQI projects, empowering them all to upskill in SusQI, influence their clinical pathways, and reduce the environmental impacts of their clinical decisions. And looking at one project in a bit more detail, one trainee looked at investigating paper waste in an oral and maxillofacial surgery unit associated with the patient letters being returned to clinicians for adjustments before being sent out by secretaries. All of the letters were printed out and duplicated depending on the number of recipients required. And she found that 47% of all these letters required adjustments for things like spelling, additions, grammar, clarity, and removing content. And the amount of paper waste built up. So 688 pieces a month, which equals 8,256 pieces of paper with no clinical benefit wasted annually. So they educated the clinical and the secretarial staff on improving the quality of their first dictations. They embedded this information into their induction programs for staff, which is especially important because of the rotational nature of the posts. And they recommended electronic dictation software, which seems like the obvious next step to go. And I know that the second cycle of this audit is underway. And how did they demonstrate their outcomes? So they looked at the clinical outcomes as well as the triple bottom line. So clinical outcomes, the letters, if they're improved and the first dictations are improved, can be circulated much quicker, streamlining and improving the quality of their care. Confidential waste comes with a return trip of 22 miles in this trust and a carbon footprint of over 1 tonne of CO2 equivalent a year. So less paper waste reduces the frequency of the collections and its footprint. Prompt clinical letters improves the quality of work life for secretaries and clinicians, freeing them up for other things. And there's also an opportunity for improved teamwork cohesiveness as well. And economic savings associated with saving 8,000 pieces of paper a year, as well as reductions in payouts to the confidential waste companies. And their conclusion was that they found there was an improved general awareness of paper waste in the department, its repercussions, and accountability within all members of their team. And just to quickly go over some other examples in dental core training, we had someone develop a green space for a community dental practice. There was an audit on antimicrobial stewardship, reducing more paper use through oral and maxillofacial surgery pro formas. And there was a project that looked at improving the sustainability for the referral pathway for young people requiring treatment for impacted teeth, which resulted in less number of appointments and improved reductions in transport, so therefore a marked reduction in CO2. So why is this important? So I'm going to give you a minute just to read this testimonial from a DCT in the previous year's cohort. So this is why it's important. So it's more than just what they've managed to change on a local level through their project. It's about them changing their actual mindset and inspiring them to then influence change as they go through their career. So what next? The quality of the projects and the enthusiasm of the trainees to work towards a more sustainable health service is a testament of what DCTs are willing to do and determined to do for their future in healthcare within a very busy 1 year when given the tools and empowerment. And now it's established and well accepted, the DCT SusQI programme will continue to be an evidence base of behaviour change in both trainees and their workplaces. A body of projects is being created that will act as a record of activity, a resource for research and project subjects to then recycle for future cohorts. And there is research currently underway on the impact of this sustainability training on trainee behaviours, and the programme has been adapted for dental specialty training and delivered this March. And that's the big question, how to nationalise. This is great, this is all going on in Yorkshire, but to advance sustainable dentistry at the speed and scale required, this programme could be adapted nationally to suit medical and dental programmes at different all levels and in all specialties, including allied health professionals as well. So it would be really great to be able to discuss how this could be possible within all our different areas around the UK. And I always like to end on this quote, some of you might have seen this a few times now, but in the words of John Elkington, when it comes to sustainability, the time has come to either step up or get out of the way. And we're definitely doing that in Yorkshire.
Thank you so much, Jenny. Really inspiring presentation. Thank you. I'm going to move us on to our next presenter now, and then after that we'll have time for a Q&A for our 4 presenters. So our next speaker is David Maxwell. David is the portfolio lead for talk programmes and a member of the quality improvement team at NHS Education for Scotland. In addition to having an interest in sustainability and QI, David leads and delivers QI training for individuals working in Scottish public and third sectors. David joined the QI team at NES after working as an improvement advisor for the Scottish Patient Safety Programme. And David commenced his professional career as a hospital pharmacist in Australia, specialising in infectious diseases and quality use of medicine. So thank you, David, and welcome.
Thanks, Kath, very much. Can I just double check that you can see my slides okay?
Yeah, we can, yeah.
Brilliant, that's a good start. So thank you, and it's great to be here, and thanks for the introduction, Kath. So just to give a bit of context before we start, and I think it's fair to say I'm potentially going to be bringing a slightly different angle in terms of our approach, and particularly because of the organisation that I work in. So the QI team is part of NHS Education for Scotland, and we have a remit for providing quality improvement training to a wide group of stakeholders. So just to give you a bit of a flavour, our target audience includes healthcare, as well as social care and the third sector, including voluntary and charity sectors, the broader public services, including things like fire, police and national parks, as well as education. for those delivering and supporting early years primary and secondary schooling. So we have a broad range of folk that will come in contact with us in terms of quality improvement, training and resources. So we have a virtual public-facing front door called the QI Zone, and that actually includes a number of different tools, resources and information, as well as details of some of the QI programs that we deliver. And I'm going to use some of these headings to help facilitate what I'm going to work through this afternoon. I think, as Iain mentioned, we have also been in a more formal collaboration with SusQI in a fairly recently. I'm joining in January this year. So we have done a bit of work, and what I'm going to share with you is what we've done so far, as well as some plans for the future. And I'm really appreciating the opportunity to hear from others as well today. In Scotland, we've got what we refer to quite nicely as the quality improvement journey. And this particular journey forms the basis of all of our QI programs that we deliver, and also the resources that are available through the QI Zone. We currently deliver 3 key quality improvement training programs. The Scottish Quality and Safety Fellowship, which is a 10-month program focused on clinical leaders. The Scottish Improvement Leaders Program, which is open to anybody across the Scottish Public Service that has a lead role in improvement, as well as the Coaching and Leading for Improvement program, which is targeting managers and leaders of teams to support them to deliver quality improvement. I am going to come back to these later on in the presentation. So just in terms of sharing progress so far, and again, calling upon our good old quality improvement journey, as part of the creating the conditions to support and promote sustainability and the agenda to start with, we've published 3 new pages on the QI Zone, again, publicly facing. The first one raising the climate emergency and also the relevance to healthcare and Scotland's response to the climate emergency. We've also published a page on how the quality improvement journey can support projects related to sustainability. And finally, and I think just as importantly, sharing a number of projects and case studies, which includes SusQI resources and examples, as well as some projects and initiatives in Scotland. As part of our initial work, we mapped at a fairly high level the SusQI framework and the quality improvement journey. And we're able to confirm too that these approaches are core to the model for improvement as a method to support quality improvement. So we're aligning quite well in the opportunity to incorporate sustainability principles into our existing resources. We also pose the statement of sustainability, things you can do for each stage of the quality improvement journey. And challenging people to think about in terms of creating conditions, what specifically might you be able to do in relation to sustainability? And we also use the opportunity to promote and connect to any existing Scottish agendas and strategies, and in particular, the value-based health and care approach that is part of Scotland's strategy at the moment, as well as the NHS Scotland's climate and emergency sustainability strategy. We also went through, and I'm not going to go through these in detail, but in terms of understanding your system, things you can do, developing your aims in relation to sustainability, testing changes, when you come to implement and spread, and just to finish with measurement, leadership, and communication. And I'll start to now show you some specific things that we've incorporated into the existing resources. So we talk about the project charter. So with the project charter, we've intentionally now added at the top of every project charter template, the dimensions of quality, which now include sustainable. So we're getting our learners to think about from the outset, which are the dimensions of quality their projects align with. Also with the hope that they'll be thinking about sustainability now as part of their work. We've also in the rationale included a prompt explicitly talking about the outcomes for people and populations potentially, but also the impact in terms of the resource use about the environment, finance, and people. We've also updated our measurement plan template with a specific prompt where relevant to describe how their current measures would contribute to sustainable value. And I think that's accepting that some measures perhaps just need that prompt and a conversation to make the connection, while others might actually include a brand new measure to be very explicitly measuring something like the environmental impact. We've also incorporated and strengthened our teaching around balancing measures, again, to ensure that any improvement is not creating inequity within the system, but also to be monitoring any unintended consequence on resource use, like environment, finance, and social. We're also now considering too the concepts in terms of prevention, patient empowerment, lean pathways, and low carbon alternatives and estates provided by SusQI as how we can use these as idea generation exercises when we identify change ideas that we can test within the system. One of the things that I do know that's going to help people get on board, and that's the power of using real life examples. And that's one thing that we know is going to be really helpful and continues to be helpful in engaging others. We also know that there's probably two groups of people that come into our educational programs. One, that the sustainability is the reason that their project exists, but others that we need to support to make them think a little bit more broadly about some of the sustainable value elements they could be incorporating into their work. So some specific examples that we're able to share through the Scottish work that's already been done focus on things like reducing food waste in hospital, looking at appropriate clinical waste disposal, as well as supporting children in a high school to increase the amount of plastics they recycle on a day-to-day basis. And with our colleagues through the Scottish Graduate Entry Medical Programme, there are a number of QI projects focused on planetary health, looking at reducing carbon footprint to and from a GP practice, and also focusing on appropriate use of metered dose inhalers. So it's through these that we're able to provide specific examples of how QI tools can help people with sustainability related projects, such as the use of proto charts, as well as fishbone diagrams. These are just some examples, and work is ongoing. And again, I'm really pleased to be here to hear from others today. So I just wanted to share with you a couple of other things that we have on our pipeline in terms of work. Early next month, we're meeting with colleagues in SusQI to help us explore a little bit more about how we can use carbon footprinting in existing projects. And so we're going to be looking at a particular project that was focused on sustainability and antimicrobial stewardship, and to be able to report much more explicitly on the potential carbon footprint reduction as a result of those improvements. We're also looking at seeing how we support graduates from our programs. We've got a number of people who have already completed our QI training programs. So how do we support them? So we're thinking in terms of running specific workshops for our alumni, promoting the idea of sustainability and quality improvement together, and potentially looking at animation and how we can describe and link QI to sustainability, and continuing to share examples, because again, I do strongly believe that's the one thing that's going to help other people engage to see how it can be done. And I think just as importantly, how we continue to link locally with the Scottish agenda, particularly around value-based health and care and the government's response to the climate emergency. So that's me, and I just want to thank you again for the opportunity to be here today and for sharing where we're at in Scotland. Thank you.
David, thank you so much again, just so much amazing work you've been doing in Scotland. So thank you so much. So that is the end of our first section of presenters, and we now got around 13-14 minutes for a Q&A for some of our presenters and panelists.
So yeah, thanks everyone who's posted a question in the Q&A, and do keep them coming and we'll try and answer them. But if we don't get through them in this session, then we'll ask our speakers. I'm sure we'll pick them up on the platform as well. But first, Iain, I've got a question of, it might be early days, but how did the Trust, or how does the Trust plan to measure the impact of adding SusQI teaching methods into your in-house QI training?
Yeah, thanks, Frances. Yeah, it is early days. I guess it's how are we and how are we planning to do it? So I guess from a process measure perspective, we are looking at sort of confidence scores for the people undertaking the training, both teams and our coaches. So we've just started cohort 3 of our training program at the end of April, and so they're running through the course of the next few months and into the autumn. So some confidence scores for those people around their understanding of sustainability and their ability to sort of measure on that going forward. And from an outcome perspective, we use Life QI within the Trust in terms of logging projects. Probably half answers another question that's going to come, but we're using the tag North Sustainability for where improvements have sustainability metrics applied to them. So I guess as we go forward, we would look to see an increase in both the number and proportion of projects that have that North Sustainability tag applied to them.
Brilliant, thank you. And Yeah, I mean, it would be lovely in the longer term to be able to measure the particular sustainability impacts of those projects as well. And that's something that we at CSH are also really interested to do with our partners long term, and hope to be able to really show that sort of value chain all the way through in the future.
Absolutely. I mean, each of the projects themselves will have their own SUS measures, but it's then consolidating them up into something that's reportable at a corporate level.
Yeah, because we don't want to sort of we want to do that in a sort of meaningful way. We don't just want to sort of add together too many apples and oranges. Brilliant, thanks so much, Iain. And but moving on to Jocelyne. Jocelyne, there was one question in the chat which I had a go at answering, which was quite a tricky one about how by a project that reduces length of stay contributes to sustainability, and if the bed gets filled. Did you want to add anything to that? It's a tricky one, isn't it?
Yes, I mean, I guess one of the things it does do is reduce the delay of somebody waiting. So if you're looking at, health getting worse while people are waiting because of the stress of waiting, or people stuck in casualty because they can't get into, that might be the thing that causes or prevents the issue from length of stay. But they're using length of stay to look at whether measures do actually prevent resources being used. So I've got some other projects where they're looking at clinics, for example, that if the clinics work right post-surgery, then length of, people know what they're doing when they come out post-surgery, and then the length of stay is reduced and they seem to have fewer complications. So that's how it's working in the projects that I've seen. Yeah, but I'm supervising quite a lot of projects, so they get muddled in my head.
Yeah. And there are metrics that have been developed, aren't there, that estimate the carbon footprint of an average inpatient bed day and some critical care, or just a normal bed day. And
some of the students are putting that in their discussions, how much it would cost for a bed day, and extrapolating that up for the amount they've saved across the project.
Yeah. I mean, it's obviously a very thin slice of the whole carbon footprint of that hospital working that day for inpatients, isn't it? But thank you very much. I'm going to move on to Jenny, just make sure we get at least one question for each panelist. Jenny, as most of us here probably visit the dentist or hygienist occasionally, is there anything we as patients can do to spread the word to our, I think that would mean dentists and dental professionals, about SusQI and sustainable dentistry?
So I saw this in the chat and thought, what a fantastic question, because patients, we need to be doing shared delivery of care, etc. So them advocating for change is just really, really important. So I think as a patient at your treatment appointment or your checkup, you can ask to see their sustainability policies, or even just starting the conversation as a startup. Because they will have to have sustainability policies now, because the CQC are implementing environmental sustainability into the regulations as of autumn 23. So it's something that's definitely on the mind of most dental practices, and having that conversation you can then discuss whether you need to, do I need to come in 6 months' time? Can I come in 12 months' time? What's the sustainability of this treatment option versus this one, for example? And even if they don't know, you can then, you started that conversation up, and then they'd be interested in looking to find out the answer for you. You can also signpost to programs, depending on how the conversation goes. So the CSH programs, even just an introduction to sustainability, the sustainable dentistry programs. There's an e-learning for health, sustainable dentistry module that's recently been launched, and that's free to access as long as you've got, it says any email address, but I just had to double check whether you have to have an NHS email for that. But all dental practices are eligible. They work in NHS to get one of those. So it's just signposting. There's clinical guidelines, new CQC regulation, and SusQI programs as well. So as a patient, I think you are in a very powerful position to start the conversation persuade and educate the dentist as well, because you're both equals.
Thank you so much, Jenny. Yeah, there's clearly so many conversations to be had, and yeah, it's about starting them, isn't it, really? David, I really appreciated your presentation with the examples of how you've really threaded sustainability through your existing materials, and I really demonstrated beautifully that you're not setting out and creating a new one, you're threading it in. And what have you found the most difficult thing on your sustainable healthcare or sustainable QI journey so far?
If I'm going to be honest, if you consider the amount of time and space you have with people to learn and educate, it's just real estate. It's that, what is it that's going to be the most important things to include? Because we've got a finite set of time that we've got with people. So including this, we're having to reprioritize what else or how else can we support learners to direct them either through self-directed learning or other ways of actually picking up all of the rest of the content. So I think that for me is just one practical element of just the challenge of, if this goes in, how do we support other learning? And that's as I think as nuts and bolts as we can get in terms of the challenge. But I do think that over time, even the priority and sustainability being on more people's minds is going to make this much easier in terms of the reason why we're focusing on what we are. I hope that's helpful.
Yeah, it's space and time with our learners is the currency, isn't it?
Yeah.
Your materials, have your materials gone into use yet, or are they still in? Yeah,
so the most of what I've shown today is actually incorporated into at least two of the programs that I've mentioned in terms of the Scottish Improvement Leads program and the Scottish Coaching and Leading for Improvement program. But again, a lot of those are now also just publicly available on the QI Zone as a downloadable resource as well. So it's freely accessible as well as part of our teaching.
So it'll be really interesting to hear how people get on with those, isn't it? Thank you. How am I doing for time? Kath, have I got any more time for questions?
Yeah, we've got another 5 minutes.
Yeah, okay, great. Well, I just wondered if any of the other panelists might like to share their challenges that they've found when they've been doing this work.
I'm happy to jump in, Frances. I think from a Newcastle perspective, it's been that quick adoption and changing of our materials. So we've really had to be agile in terms of getting that through. But the measurement piece and trying to keep it simple for people. So we're fortunate, I guess, that our sustainability team, our Shine team, are really great at supporting individual projects with their measurements and trying to demystify some of the challenges that go with trying to convert everything into CO2. And actually, just enough data is good enough. So, providing the postcodes in order to do miles saved, or just counting the single-use items saved, and then kind of handing it over to the experts to be able to help out. So, but it is not just from a sustainability perspective. Measurement's difficult. People get caught up in trying to have perfection with regard to measurement instead of just finding enough. So I think that's our biggest challenge in Newcastle.
So do you think your team's going to be quite hands-on with the measurement side in the early days, or are people managing to access what they need?
No, I think from a corporate improvement team, we're having to be quite hands-on with measurement across the board, showing people how to access the systems, and as I say, even just setting up things that allow them to do 5-bar gates and stuff like that. It's just that being there and ensuring that people continue to count and collect that data. So it's just the prompts, really. People are capable of doing it. It's almost just the capacity to think about how they're going to do it.
Yeah, thank you. Thanks, Iain. Jenny or Jocelyne, did you have any challenges you are able to share? Jenny, maybe first.
Yeah, sorry, I can't see if Jocelyne's got a hand up.
No, go.
One of our main challenges is the rotational aspect of the trainees within the programme. So it's about time and when to deliver it, to be able to give them enough time to have outcomes, but also be supported when they come up with inevitable challenges. So that's why I think it's more important to get the values embedded into them as they move on, and for just continuous encouragement to stick to their set goal, you know, as per the 4-step SusQI protocol. So we do spend a lot of time talking about the challenges with the trainees and supporting them through them, but time is always going to be an issue when they're in post for 6 to 12 months.
Yeah, thank you. Jocelyne.
Yeah. And challenges for our students is also time. I mean, they're doing a project which carries on outside of the dissertation, but they have a year from when they start with us to when they have to submit the dissertation, and they might not get there very far. Also, they're all working in their own clinical organisations. They have things like COVID that come their way. They have all sorts of high-level roles, which means they're working, trying to do their projects, build a stakeholder team, all of the administration stuff at the same time as they're working in those high-level roles, and then they have this kind of submission deadline, and they're all challenges for them in how much they do. And I think that might be a reason why some of them perhaps don't choose to use a method that might appear to them to be complicated. Some may choose their QI design because it seems easier to them, or because it's something that the trusts that they work in promote a certain type of design, which might not be a SusQI design. So we're asking them to do something they don't necessarily see on top. So I think that's probably a challenge in them using it.
Yeah. And every project is like a little gem, isn't it? That so much has gone into it. And when you see them coming out, it's, you know, and you know what it's been like working in the NHS this year as well. You just kind of, we need to have a little celebration for each one, don't we?
Yeah. We've got more examples we can show to the current students now of how someone has written about sustainability in their discussion. We've had a couple of students who volunteered their parts of their project excerpts that can be shown. So I think, and some of those students now come in and talk to the next cohort. So I think that will help people going forwards.
I can imagine. That's fantastic. Thank you so much to all 4 of our panelists. It's really fantastic to hear from people who are right at the sharp end of putting this into practice in your organisations, and we are really privileged to be working with all of you as well, so thank you. So we are going to go on to part 2 of the session, which is all about more detail on some example projects. And Kath, shall I hand over to you to introduce?
Yeah, thank you, Frances.
Thanks.
Great. Yeah, so as Frances says, we're going to talk about sort of practical in practice examples of sustainability in QI. So our next speakers are Angela Hayes, a clinical nurse specialist employed in the specialist supportive and palliative care team at the Christie Foundation Trust, and Alexandra Langstaff, who's a ward manager for head, neck and brachytherapy and molecular radiation, also at the Christie in Manchester. So a little bit of background. Angela has a background in intensive care management and teaching, and leads on the corneal donation in her trust. Also a climate change activist who's really passionate about engaging healthcare professionals and sustainability. She's presented on this subject widely. She's also a carbon literacy advisor, a NetZero advisor, and a clinical sustainability lead in her trust. She's received a prize for her sustainability work in the Best Social Responsibility Programme category at the Nursing Times Workforce Awards. Alexandra is an adult nursing graduate with an MSc in specialist cancer nursing. She's an interest in symptom control and end-of-life care, which led her to her current position at the Christie, where in 2022 she was involved in research describing the debilitating symptom of mucositis in her unit, which is what their project is around. She's a strong passion for staff mental health and well-being, and is a clinical supervisor in her trust. So welcome, Angela and Alexandra, great to have you here.
So I first of all have to apologise because Alex can't be here. Unfortunately, clinical commitments have meant that she's handed over the presentation to me. So I hope I can kind of answer the questions that normally would have fallen to Alex. So I'll begin the presentation, so do bear with me. So photobiomodulation therapy was the project that the palliative care led by Alex did as part of the Green Team competition. Photobiomodulation treating mucositis in patients with base of tongue and tonsillar cancers. So just for a bit of background, mucositis is very common in patients following chemo and radiotherapy. There's a horrible picture there of somebody struggling with that condition. Results in patients experiencing very severe pain and complications. And they need, on many occasions, admission to hospital for pain and nutrition. Often quite complex is the management of these patients. They pose a significant risk of getting infections and sepsis. And along with these problems, they experience problems from a range of different reasons, really, from physical, psychological, and the problems have a real social impact on patients if they have nasogastric tubes, if they find it difficult to eat. So it's all kind of those, very much those things that we rely on in our social lives that is very disturbed in these patients. So the PBM, this is a picture of Alex with the machine there, and what PBM or photobiomodulation therapy does is it treats patients to prevent mucositis by applying a light source, which does three things. It increases the cell metabolism, it promotes healing, and is all about reducing inflammation. It's really, really simple to use. Once the patients have been shown how to use it, they can pretty much do it themselves, and it also has NICE approval. And this is a picture of Paul from the company Thor, who produced this machine, just demonstrating the use of it. So there's two elements to the photobiomodulation. There's like a lollipop probe that goes inside the mouth, and then there's a head on the machine that is a bit like a shower head, and it goes outside of the mouth. So it's kind of tackled from both respects, and the patients have to have a minute of therapy for each. So what Alex did in her study, she looked at 22 patients, 11 formed the control group, 12 as part of the treatment arm. With the control group, she obtained patient data retrospectively. In the treatment arm, she had patients who had 30 sessions of PBM that ran alongside their radiotherapy. So it didn't involve extra visits to the hospital, extra appointments. They had them just before going for their radiotherapy appointment. In total, a 50-minute session with PBM at very low staff input was required from a training perspective. So it's very simple to use. You just kind of put the lolly in or put the shower head on your cheek and off you go, turn the button on and off you go. So the retrospective data collection, what Alex looked at was the severity of mucositis symptoms. She looked at the frequency and length of unplanned admissions, the type and dose of medications that were required to control pain, and then what further treatment the patients then went on to require, what interventions they had. And she looked at whether or not that included nasogastric tubes or antibiotics. So while Alex was doing this, I was working on my sustainability projects, and like I say to everybody, I can't ever, now knowing what I know about the environment, remove these sustainability lenses. I see everything through this perspective, and kind of want to talk about it with managers, with colleagues, with patients, with my family, with anybody I come into contact with. I've left off politicians there, they've not escaped. But as healthcare professionals, I wanted to kind of put across that we have a really strong voice with regards whatever we say, really, and therefore we should use it to kind of get across our agenda in a real clever way, in a way that we're very much trusted. You know what we say, we're very much trusted, so we can influence people. So I was doing this sustainability work, Alex was doing her project anyway, and I kind of didn't think the two were related until I heard the outcomes of this, and it made me think, well, actually this would be really good from a green perspective. So like we all kind of realise that healthcare plays a significant part in global emissions, accounting for around 4%, equivalent to all of those from Denmark. And if it were a country, it would be the 5th largest polluter. Simon Stevens has claimed that climate change poses the most profound effect human public health, and that avoidable deaths are happening. So we need to be acting now. Climate change threatens to undermine the gains we've made to public health over the last 50 years. So all of that, bearing all of that in mind, when the Green Team competition was introduced and we got the funding to introduce it into our hospital, I suggested to Alex that PBM might be a really good project to consider as part of the Green Team competition. So looking at improvements for patients with a reduction in the environmental, social and financial implications of our treatment, so that triple bottom line. And I felt the PBM really kind of stood a good chance of meeting all of these requirements and, you know, been a strong contester. So this was a picture of Paul from PBN Thor, who, when I mentioned about the green side of his treatment, he said he'd never heard of this. Nobody had ever mentioned it. Each time he'd been out talking about the benefits of PBM, he said, nobody's ever mentioned this to me. And I was going, you're kidding, aren't you? I said, this is how I see everything. But this could be a real string to the bow of this treatment therapy, that it has this added green benefit to it. So what then Alex did as part of the Green Team was that she looked at the retrospective data that she'd collected, and then she added in, as part of the Green Team competition, other things that then looked at the more environmental impacts of the study. So all of the other things that she'd mentioned, severity of symptoms, hospital stays, all the medication. She also looked at when medication was commenced and what medication was in use 6 weeks post-treatment. We measured the environmental impacts of all of this as well. So the results of the 11 patients, Alex was able to demonstrate financial, social, environmental improvements. We demonstrated reduced hospital bed days by 63, with a 64% reduction in analgesic requirements, with cost savings of just these 11 patients of around £33,000. We demonstrated carbon reduction equivalent to over 2,500 kilograms of CO2 equivalent, and we could see huge benefits in social the social element, so massive improvement in quality of life, physical, psychological improvements. We were able to demonstrate there was a quicker recovery, there was an ease of use in treatment, and it was non-invasive, so there was a real patient empowerment element to the treatment. I've already mentioned it had minimal staffing implications, and it was delivered alongside radiotherapy. With this, we were able to predict the benefits of this treatment over a year with all of the patients that we wanted to treat. And after the purchase of 6 of the devices, we were able to show savings of over £530,000 a year, around 43,000 kilograms of CO2, which equated to around 130,000 miles driven in an average car. And the winner of the Green Team competition at our trust was photobiomodulation. Going forward, what we plan to do is we hope to buy 6 machines to use as part of the treatment protocols for this particular group of patients. We have a business case that we're due to have a meeting in a week or two to buy 6 devices. Sorry, that's a misspelling on there. And kind of say integrate this as part of the treatment therapies. We've been involved as well with the PBM machine in marketing this with its green credentials as well. Alex and I were at a conference only yesterday, an oncology conference, talking about the sustainability aspect of this this treatment. And we've also feel that it could be beneficial in other areas. Again, there's another typo on there that should say lymphedema. So breast cancer related to lymphedema, radiation, fibrosis, and stem cell transplant in our patients. Alex and I have written about not only the Green Team competition, but about PBM particularly. So we have publications that are due out in nursing journals in the summer.
Thank you so much for your presentation. But yeah, brilliant to hear.
That's all right.
viewing the project through that sustainability lens and how that's fed into everything you do now in your personal life as well. So thank you so much. But I'm going to move us on to our next presenter, who is Dr. Lynn Riddell. Lynn is a consultant physician currently working as the lead for integrated sexual health services across Northamptonshire. Her undergraduate degree was at the University of Cape Town in South Africa, and her postgraduate training was through St Bartholomew's Hospital, London and Oxford, and is going to talk about her SusQI project in the HIV service. So thank you, Lynn.
Okay, I want to present a pathway, which is actually a clinical pathway transformation that we did for the Green Team, and it achieved the triple bottom line. So although it's very specific about HIV, the reason I think it's very important is that it's so translatable across so many areas of the NHS. So I'm just going to give you a bit of background. So we are a county-wide service, and Northamptonshire is a very long county. So we have two main towns, which are Northampton and Kettering, and then we have our patients travel from all sides of the county. So sometimes they could have up to a 50-mile journey to reach services, and that's actually really important. And then just looking back at HIV care, for those of you who are not familiar, so in the 1990s, we didn't have any antiretrovirals. So as HIV progressed in an individual, their immune system became severely compromised, and they got opportunist infections. And it was those opportunist infections that brought them into hospital. And they either lived or they didn't live. And those who lived went out again, and they came back 2 or 3 weeks later, either with the same opportunist infection or they came back with a different one. And so we used to see people every 2 or 3 weeks, sometimes every 4 weeks. And it was a very brave person who organized to see somebody for a follow-up that was more than 1 month away. But that's obviously all changed. We now have excellent antiretroviral medications. We've got a background of really robust research, and so we know how to use them. And so eventually we started seeing people every 2 months, and we learned how to measure viral loads and resistance. And then we started seeing them every 3 months and eventually 4 months. And then by about 2006, people were still quite reluctantly starting to see patients every 6 months. And we haven't changed anything since then. The patients' lives have changed significantly. People with HIV can now have babies, they can have normal jobs, normal families. People are not expecting to die. And alongside that, staff, everything's changed in the NHS. You know, staff are stressed, they're more pushed for time, they're commissioning budgets, there's all sorts of complexities. So there are all sorts of reasons why we should look at this and other pathways. And of course, the reason we're all here is because of the increasing awareness of what the NHS does to the environment. Oh, sorry, I can't seem to move that slide on.
If you click on the slide, it will release it.
Oh, there we go. So some of this, thank you. This is about breaking habits and understanding what really hurts. So what really is hurting the patient about them coming up to see us, you know, every 6 months? And what is the fear about changing it? Because it's often not what we found through this project was it wasn't the patients who were worried about changing the pathway. It was very much about staff. And a lot of those staff were older staff. And I think some of their fear was about, well, you know, if you don't need me, then I'm not going to have a job, or they were just too overwhelmed to make changes. They didn't have time to think about it. So the question to everyone is, you know, are you worried about the environment, and are you worried enough to actually change behavior? Oh, sorry, now I need to go back. Okay, there we go. So we had learned during the pandemic that there were patients that it was too high risk to bring them into the service, because we were bringing them in for a blood test, but there was such bad COVID within the hospital that they were at high risk. So this was before vaccination. So we had to come up with a way of looking at each individual patient and saying, do they actually need this blood test, or actually can we just write another prescription? So we came up with a very sort of neat way of communicating with them, and a way of managing their pharmacy requirements and their pathology requirements. And what this allowed us to do was to divide our patients into 3 groups. So there were those who we considered to be very, very stable, which we called cohort A. And they were people who'd had a viral load that had been undetectable for quite a lot of years, sometimes way back to 2006 or before. And then there were those who fell into other groups. So they were pregnant, or they were new, or they weren't on antiretrovirals, or they had complications. And the plan for this pathway was to change it so that those who were very stable, and we clearly defined what that was, to reduce their attendance from 6 months to annual. And then obviously we put in a safety netting. So if a patient didn't want to do that and they felt unsafe, then they didn't have to do that. And we estimated that our cohort at the time was roughly 1,000 patients. And we estimated that about 70% of them were stable and would be able to be offered this. And so it's actually turned out that it was much higher than that, but at the time we didn't know. And so we did all our figures based on 70% of our cohort. But to start it off, it goes back to that, who's scared of changing what? And so we started it off by not telling our staff what we were anticipating doing, but by asking our patients. So for the first 100 patients who came in, we asked them, how do you get here? Do you come by car? Is it diesel? Is it petrol? Do you come by bus? Do you bike, etc.? How much does it cost you to park? How many hours does it take from door to door? Do you have to take time off work? And we had lots of patients who were like on 0 hours contracts. So if they came to see us, they weren't getting paid. And so there were lots of complexities around that. And then we also asked them, if we think that we could keep you safe, would you be happy or unhappy to sort of change to only have bloods once a year? And that was a key question. And then we asked, are you interested in the environment? So I'll show you those figures now. So this goes into the triple bottom line. So I've divided up to that. So the majority of people drove cars, and some came 140 miles, some came more than that. And that's because for HIV care, it's open access across the UK. You don't have to receive your HIV care in the county or the town that you live in. You can go anywhere you want. So if somebody really liked us and they'd moved out of the area, they could still come and see us. And we had somebody who traveled, hundreds of miles. And so the CO2 saved was equivalent to 108 return trips between Northampton and Glasgow. And for those of you who are not sure where Northampton is, it's about an hour outside of London. So this was a really long way. And that was the saving was per year, just by changing from a 6-monthly routine appointment to an annual one. And the consumables, so all the stuff that we used, the needles and the syringes and the PPE, etc., that costed out at £85,000 alone per year. But the big thing, which is not included in that 45,000, is it saved 350 hours of band 6 nursing time and 100 hours of medics time. Now we purposely did not cost that, though you can cost it. And we didn't cost it because we were worried that then somebody would take it out of our budget and say, oh, you don't need this. But actually we did need it, because if you go back to my second slide, which was about staff stresses and everything that's going on in the NHS, we've got increasing demand, we've got increasing complexity in our patients, we've got staff who are struggling to do their CPD, their mandatory training, and just have a breathing space. So saving this time has just been a godsend for them. And since we started rolling this out, there's a whole lot of an increased demand, because a lot of people are being brought in from overseas to fill social care gaps, and it's bringing a lot more HIV that we hadn't anticipated. So that was the environment and the financial. And the social, there was a 94% approval by the patients before they'd done this and before they knew anything about this project. That survey showed a 94% approval for reduced attendance. There was a 95% approval for an electronic link communication system rather than a letter. So we send an SMS to their phone. They then log into our system and they can see what letter we've written, so that there are no letters going to their houses, because many of them live in houses of multiple occupancy. On average, there was a £9.20 direct cost of saving for whatever petrol or what method they used of transport. And 84% of them said they were environmentally concerned. And when we looked at the 16 who said they weren't or hadn't answered the question, the majority they hadn't understood the link between the NHS and the environment. And many said, we weren't sure why you were asking that. So we've rolled this out now, and we're doing a robust data collection system for later review. So let me rephrase that. We are rolling this out. Every time we see a patient who fits cohort A, we offer it to them. only 2 people have declined this, and they have declined it they were both retired, and they said, well, actually, we really like coming to see you, and we live just around the corner, and it's the one thing that we like to do. So they've had an option, they can carry on. It's been environmentally, socially, and financially hugely beneficial, with significant change to the pressure on the staff, and I cannot emphasize that enough. But I think the key thing about this is we did this for over a cohort of 1,000 patients. There are over 100,000 HIV patients registered within the UK, and yet our national guidelines still recommend a 6-month and a 6-month routine regular review. I mean, my opinion is it's absolutely not necessary. But I think this applies to multiple other specialties, and particularly outpatient services within the UK. So I just want to thank all the patients who have been a part of this, and obviously to Rachel and her team for flagging it up and for giving us the opportunity to do the study. And in Northamptonshire, the study and the Green Awards were supported by the Northamptonshire Health Charity. So I'd just like to thank them. Thanks very much.
Thank you so much, Lynn, for your presentation. Just such amazing work. It's always great to hear about this project. And please do post any questions that you have for Lynn in the chat when we get to the Q&A section. We've got a video recording now of our next presentation. So, our next speakers are Laura-Marie Baldwin from the Home Enteral Feeding and Specialist Dietitian Lead, and Sarah Williams, who's a Home Enteral Feeding Dietitian and Training Lead, both working at the Gloucestershire Hospital's NHS Foundation Trust. So we've got a pre-recorded presentation from them to share with you.
My colleague Sarah Williams, and we work for the home enteral feeding team in Gloucestershire. So our team they consist of specialist dietitians, nurses, dietetic assistant practitioners and admin staff, and our job is to look after patients in the community with an enteral feeding tube. So we have a contract with Nutricia to deliver our equipment that's required for enteral feeding. And they have announced that there's some changes to their equipment. So where you see the single-use container on the far left of the page, they have now brought out a reusable container that you see next to that, and that is suitable for use for 30 times. So this type of equipment would be used for running water through a pump, for example, or for delivering a modular type of formula feed for a patient. On the far right of the slide here, you see the giving set, which connects the equipment to the patient's feeding tube. This was originally single use, but now, after kind of thorough testing by the company, it can now be used several times within 24 hours. So there's lots of cleaning instructions that go alongside this usage. So what we did was we decided to pilot the change of these pieces of equipment at the neurological centre that we cover, and pilot our approach to implementing this. So the neurological centre has 60 beds and we have 30 patients within the unit. We initially weighed all of the equipment and calculated the carbon emissions associated with the equipment. We identified the eligible patients within the unit that could change from one to the other. We delivered 2 training sessions for the staff and carers at the neurological centre, and we asked a questionnaire of them to gauge their opinion on recycling and environment. So we then arranged delivery of the reusable equipment at a time where they could make the change. Then we followed this up with a questionnaire to the staff and carers to gather feedback on the process as a whole and how usable the new equipment was. So following our training sessions, we gathered data on how we were able to influence the views and perceptions of the staff at the neurological centre. And the training sessions changed 90% of the participants' views on the impact of healthcare on the environment. And it also increased their awareness of how their job roles could contribute to environmental sustainability. When we asked the staff following the training if they were happy with the change, they all agreed that it would be a very positive change, both for the patients and for the neurological centre as a whole. And they didn't feel that the change had impacted patient care in any way either. So we looked at the carbon savings at the neurological centre, and the change from moving from the single-use containers to the reusable containers, we were able to demonstrate a saving of 417 kilograms of carbon per year. And the increased extended life of the giving sets, so meaning that we could reduce the number of giving sets some of the patients had, we were able to demonstrate a saving of 124 kilograms of carbon a year. So this gives a total saving at the neurological centre of 542 kilograms of carbon, which is equivalent to driving 1,562 miles, or equivalent to driving from Gloucestershire to Seville in Spain. So our future plans following this project is we hope to extend the use of the sustainable products across our whole home enterally fed population. So for the single-use containers, this would encompass 101 patients who could move onto the reusable steri-feed containers, and that would lead to a carbon saving of 16,293 kilograms of carbon a year. And if we were to implement the 24-hour giving set use guidance throughout the population, that would lead to a saving of 8,428 kilograms of carbon per year. So hopefully, when we have implemented this across our population, this will lead to a carbon saving of 24,722 kilograms of carbon, or the equivalent of driving 71,204 miles, which is the equivalent of driving to Land's End to John O'Groats, I think 17.5 times. Other initiatives we're looking at within the home enteral feeding team are working with our commercial partners, so our enteral feed contractors, to seek sustainable solutions following our patient feedback. So one of the initiatives we're looking at is patients returning excess feed to the plant so it can be converted into biofuel, so it's not wasted. And we are hoping to support with other pilot projects into other sustainable products in the near future. In the home enteral feeding team, we also have 2 green champions, and we are hoping to set up a working group to listen to act on our patients' concerns and the feedback they're raising to the clinicians in the community, and working alongside the trust to promote more sustainable practices, not only in the community but in the acute setting, all to do with enteral feeding. Thank you.
Great to hear from them around their project. If people do have any really specific questions for the team, then you can direct them to us and we can pass them on if there's anything we can't answer in the Q&A, but do give your questions and comments anyway, even though they're not with us today. So our last speaker in this section before we go to the Q&A is Mr. Preetham Kodumuri, who is a consultant in trauma and orthopaedic surgery at Wrexham Maelor Hospital in North Wales. And yeah, great to have you with us, Preetham. I'll pass it over to yourself.
Thank you very much. Afternoon, everybody. Again, thank you very much for this opportunity. This is a small project we did in North Wales across a couple of hospitals. So I'm Preetham. My background is I'm an orthopedic hand surgeon, and I did this combined with Ysbyty, who's a hand surgeon from Ysbyty in Bangor as well, and we had a supervisor for this project. Vivian Lee, she's a plastic surgeon in Manchester. The main reason to take this project was because hand surgeries is a high turnaround, high volume of patients. Today, I've got about 7 to 8 patients on my list, whereas a typical orthopedic or any other list might have 3 or 4 patients. So we generate a lot of waste as a result of this, and surgery itself, as we know, is a major contributor to carbon dioxide emissions within the hospitals. And if you look at the carbon footprint, majority of it comes from the non-medical equipment and other supply chain. The scope of this project was within the theatre inside performing, when we were performing a routinely performed hand procedure such as a carpal tunnel surgery. Carpal tunnel surgery is probably the most commonest procedure we do in orthopedics and hand surgery. Almost 53,000 up to 80,000 every year in the UK are performed. And this was a simple PDSA cycle where we put our project through the various phases, and I'll show you the various aspects in a minute. But if you were to look at the sustainable QI framework, we divided this into 4 steps where we set our goals. What we wanted to achieve was mainly to look at the carbon footprint and how can we reduce the carbon footprint, and how do we actually focus on where the carbon intensive pathways within the theatre and outside the theatre were, and how can we implement a lean and a green theatre setup and green pathways for the patients to come through. And the way we wanted to measure our impact was mainly threefold. We measured the volume of clinical waste. We estimated the carbon footprint across the 2 standard and the lean and green pathways. And we also estimated the cost savings and how can we generalize this lessons to a wider other surgical procedures. So we started by simply wanting to cut down on our unnecessary usage of instruments and drapes. And we also were interested in, say, implementing a green patient pathway. And we cast our net as wide as possible. We involved everybody that we could think of within our hospital and outside the hospital, including the patient's feedback, sterile services unit, procurement, infection control, hand therapists, admin staff. We were interested in knowing where they thought we could improve on things in the way when we were doing things. And across our journey, we had support from Green Surgery Challenge, where this project was enrolled into 2021. We were lucky enough to come second in this challenge, and this project also has had support in Wales from the Bevan Commission, which supports ideas across the healthcare, and it's a great platform to come and pitch your idea, and you'll have lots of support within Wales and outside as well to have that network and support that you really need. So the picture on the left is what we wanted to implement. When I do a carpal tunnel release, I just need these instruments, 5, 6 or 7 instruments. What we were instead opening was all these instruments, which we really didn't need when we were performing carpal tunnels. And we're also opening all these packs. As you can see, there are multiple reams and reams of packs that each patient, every time a 10-minute carpal tunnel was being done, we were opening all of this single-use items, which, individually we looked at each and every one of them, and a lot of this is just not necessary. And this is how we changed our setup from picture on the right to the picture on the left to the right. So the picture on the right includes everything that we would have in a carpal tunnel setup, including the sutures, including the dressings and everything else. And we changed our drape from the left to the right, from a big drape setup where we thought it was just not necessary. We changed to 2 90 by 90 square dressings where we did not compromise on our sterility of the environment as well. The pathway that we wanted to really implement was how we would really implement change on the day of the actual procedure itself, rather than having the patient come to the ward, wait for about 3-4 hours, and then have a 10-minute procedure, go back to the ward, wait for another hour or so, and then do lots of paperwork. We wanted to try and see if we could bypass all of that and maybe bring them directly to a minor procedures room than to the main theatres. This is something which is evolving right now. So I've just left it there because this is something which is work in progress as well. But what we really looked at was how much time can you save and how much manpower can you save by changing from a traditional pathway to a green pathway. And historically, a patient would come to our ward at 7:30 in the morning, and they would go home by 1 o'clock in the afternoon. But you could see that we could halve the amount of time a patient spends in the theatre, and half the number of people could, you could free up them to do other things. So we performed about 300 cases till date across the 2 hospitals, and luckily there have been no complications. All the patients gave us excellent feedback. There was overwhelming staff feedback as well. And this is just an example of how much of waste was reduced from 3.5 kilos to 1.2 kilos per procedure. And this is just a run chart showing when we implemented our changes, when we measured our waste, this is how much it was. We could change. And we then did a carbon footprint savings. We found that we could actually decrease the carbon savings by 80%. Majority of it was because of small instruments and small drapes. And also if you could bypass the board, you could have even more savings. Cost analysis, again, we felt that we could save approximately 2/3 of cost and approximately £35 per case of a carpal tunnel we could do, but just do those 2 small changes. Just a summary of what we found. And this pretty much ticks all the 3 boxes of triple bottom for sustainability. It's great for patients, it's great for the economy, and it's great for the environment. So on the pyramid of sustainable surgery, this essentially sits right in the middle, about where lean service delivery is. It doesn't really, it pretty much might make a dent into it, but the major impact is actually on changing the patient pathways outside the theatre, and disease prevention and patient empowerment, which we are working on now. So this is what we've estimated. Just by these 2 small changes, you could save approximately £2 million across the UK and reduce almost 1.2 million tons of carbon dioxide. But more advantageously, reduced short stay in the hospital. You could do much more procedures, so there is increased productivity as well, and it's much cheaper. So where do we want to go from here? We want to expand this to other operative procedures. So I'm now engaging my orthoplasty colleagues to use this as a template to work towards other procedures which might have reproducible steps like total hip or total knee replacement. We're in the process of collecting information for carbon footprint for those are the really big carbon dioxide generating procedures. And we're also in line with GERF guidelines, Get It Right First Time guidelines, trying to move out of theatres to performing these minor hand surgery procedures by performing this in a MOPS room or a minor procedures room. And at our hospital locally, we're going to open this next week. This is just an algorithm that I've just put in there for people to go away. There are multiple areas that you can look at, not just within the theatre, but outside the theatre as well. Thank you very much.
Thank you so much for a wonderful presentation and such an amazing project. So thank you so much. So we're going to go to Q&A now.
Thanks very much, Kath, and to all of the presenters. We've got a couple of questions so far. Is Lynn, are you around?
Yeah, I'm here.
Okay, great. And well, there's a question for you a little bit about did you consider doing any remote or telephone reviews? I think that is part of the pathway, isn't it?
No, we do that anyway. This was very much about this is very much about when you have to bring people in to do their bloods. So we do the remote anyway, but this pathway was like, we routine used to bring everyone back every 6 months to have viral loads, full blood counts, etc., etc. And what would happen if you changed that? And that's where the consumable saving is. So we haven't increased or changed our program around phoning people or telemedicine. This was just about attendances.
Great, thank you. So hopefully that answers the question. If you've got any follow-up questions, do post those as well. We'll try and pick that up. And if Angela comes back, then do let us know. But Preetham, there's some questions for you about your project, and one interesting one is, do you have any ideas that would fall under the heading of prevention for orthopaedic surgery?
Great question, thank you. Yes, definitely, because we tend to, as clinicians, tend to pick up the patients once they've developed a problem. So certainly with our association, the British Orthopaedic Association and the hand surgery, there's a lot of work happening, the European hand surgery as well, on prevention, specifically when it's related to trauma. What can we do in terms of trauma prevention? A lot of what I deal with is osteoarthritis and Dupuytren, so all of that. So there is a lot of research going into that. So I suspect it'll take another 5 to 10 years for that to really come to fruition. but there is a lot of work happening in preventative care and patient empowerment. Probably other people have presented this as well. We have largely taken on patient-initiated follow-ups, remote consultations, and discharges. So there's a lot of patient empowerment and engagement in. But preventative care, I think a lot of it is work has been done in trauma side of things.
Are there occupational exposures that are contributing to hand problems that need surgery?
That's a difficult one to answer, because there isn't any specific occupation which has definitely been tied into a hand disorder on its own. The repetitive strain injury or the stress injury has a temporal effect on it, but not a direct causative effect. Because that information is lacking, you can't really advise somebody to either prevent or stop from doing something.
Yeah, thank you very much. And just one more question for you, Preetham, so far. Did you have anyone like a fellow or additional capacity to help you drive this project, apart from the support that you got through the Green Surgery Challenge?
So the short answer is no, but within our hospital, we formed a green group, which is very active. And there are regular meetings that happen, and I do know that we've appointed a sustainability fellow recently, but we probably will look for them or for their help and collaboration when we are now expanding the work into bigger other specialities. But up until now, we haven't had any direct help from sustainability fellows or anything like that in the hospital.
Well, that's even more impressive. Well done. So thanks so much, Preetham. I've got a couple more questions for Lynn. Lynn, two really. One is, do you think there would be a role for patient-initiated follow-up? And another question about whether the blood test could be done locally, whether people need to come up to the hospital.
So there is patient-initiated follow-up. That's part of our safety netting. So patients not only do not have to go into the system, but if they are in the system, like as in any time that currently exists, if there is a problem, they phone us and we see them. So yeah, there's a safety net for that, and it can be initiated by them. And sorry, what was the other question about bloods being done locally?
Yeah.
The difficulty with that is getting them to the pathology lab. So yes, you can do some locally, but the majority of people actually live in either Northampton or Kettering. So there are a few outliers who need to travel. So we wanted to do something that addressed the bulk of the patients as well, which were, you know, £9.2 because you're catching a bus or something. So I think it still would be cost effective to do it from one site. The biggest improvement is not doing it. Do you have to do this? This is just a habit that we've kept on from 2006. You know, before it was necessary, it's no longer necessary. I mean, I can honestly tell you, I've got patients who, I mean, I wasn't here then, but I've got patients who've had HIV and it's been under control since way back 2002, 2001, and they're still getting the same blood tests and nothing happens except it generates another prescription. So if you've been okay for 22 years, why would you suddenly not be okay? So because it's a little bit more complicated, I didn't have time to tell you. So what we've done is we've made the annual medical review really robust. So there's a lot more time given to the clinician who sees them annually. And then in the 6 months in between, where they would have come in for blood tests and they're not coming in, they get a pharmacy review, which is pretty much about pharmacy, but it's done by either the HIV pharmacist or one of the doctors. So again, it's a point of contact that is scheduled. And if there's any problem, you just bring them back in. So far, no problem, touch wood.
Brilliant, thank you so much. Well, enormous thanks to all of our speakers and to the participants, and the questions have been brilliant, and thank you to everybody who's commented and responded to each other's questions as well. Lots for all of us to learn from, and including for you. So I am just going to share my screen. I think you should have seen in the chat a link to the feedback from this event. We would really appreciate your feedback to help us with future events and making them as good as possible. We've just got a couple more minutes left just for me to run through resources, because if you have liked what you've seen about SusQI or about the approaches that are being taken to embed it into organisations, we have lots of resources that might be helpful to you, and offers of additional support if you need them. So the main one to point you to is the susqi.org website, because that's where you can find the open source, the open access educator pack, and also the step-by-step guide for anyone who's doing a project or supervising a project. So lots of templates and tools to help you think through each step of the project. The other things I wanted to tell you about are our Green Ward competition or Green Team competition, which is quite a structured programme which organisations commission from CSH to provide support for 6 teams to develop a project over 10-12 weeks. And a lot of the examples that you've heard of today have come through that competition, because it really does create momentum and really high quality projects with data collection and things as well, and a bit of a buzz in your organisation. So do have a look at that if that's useful. And the SusQI Academy is most relevant to the first part of today's workshop event, where we heard about those SusQI leads in organisations who are embedding it into their training, or embedding it into other aspects of QI support in their organisation. And the other thing we do is we run courses online. We've got quite a wide range of different courses. The usual format is some online materials that you work through in self-study that takes about half a day, and then a couple of weeks later a half-day workshop online where you get to meet other people and think through how you can apply what you've learned. And then you can drop in after that to quarterly or regular anyway sustainability cafes to catch up on your project and get a bit more support if you need. So do look those up if that's helpful. But main thing to say is I hope you are as enthusiastic about SusQI and all the work that's going on in our these wonderful organisations as we are. It's really all about putting sustainability right into where clinical care is thought about and where clinical decisions are made. And when we're trying to innovate and improve our service, that's just making sure we're always improving environmental and social sustainability at the same time. So we're all about getting knowledge into action and then sharing case studies. So do please look up our networks, so you can come find those case studies on the networks.sustainablehealthcare.org.uk site, and you can join and connect with other people from your specialty. But I say thank you very, very much